Good evening, everyone, and welcome to this meeting of the API. The first part of the program will be the speech by the talk by the two interventional radiologists. The minimally invasive approach, the future of modern medicine. Now, just going back in time, when I was doing my PG, the only radiology available was conventional radiology. And the masterpiece from the radiology department was a double barium contrast study was the maximum they used to do. Subsequently, over the years, the field of radiology has improved with new technologies, new imaging techniques, and the subspecialty of the interventional radiologists has come out. Now, I think they are in the forefront of diagnostic, therapeutic, and even palliative care. These few words, I request Dr. The first speaker to take over this. Nice.
Respected Chairperson and dear audience, among the audience I see many familiar faces and few unfamiliar ones. So a warm good evening to you all. So first of all, interventional radiology. So what is interventional radiology and what is the future? So just to say a few brief words. If you look at the history of Lisie Hospital itself, Lisie Hospital in the last 3 years has done maximum investment in interventional radiology department. So such a big hospital like Lisie, where it has all the specialties in the hospital, all the specialties that can be there, and still it invests maximum in interventional radiology. That itself gives us an idea what is the scope of interventional radiology, what is the future for interventional radiology. So now coming to topic proper. So this is Dr. Charles Theodore Daughter, is the father of interventional radiology. He put the stepping stone for all interventions that they are. He performed this angioplasty of a lady who was advised amputation, a diabetic lady who was advised amputation. The surgeons said nothing else can be done. And Dr. Daughter, who already had an idea, it was not an accidental procedure, he already had an idea. Radiologists were doing diagnostic angiograms then. He had an idea that if we can do diagnostic angiograms with slight modification, we can use it as a therapeutic procedure. And before he did this procedure, what he said was, a catheter in the hand of a man with imagination can be a powerful surgical tool. And with this procedure, he kept a stepping stone that proved the foundation of interventional radiology, interventional cardiology, interventional urology, interventional nephrology, interventional neurology, interventional gastroenterology, everything that all the specialties are now dealing with interventions. So this is the procedure that put the stepping stone for all the subsequent interventions that were developed. So what are our branches? Interventional radiology, the most important branch is endovascular surgery, as we said, discussed. Interventional oncology, we do intervention gastroenterology, neuroradiology, nephrology, urology, gynecology, musculoskeletal interventions, pediatric, you name a department in the hospital that deals with patients directly, and we'll deal with them. So what are the milestones pioneered by interventional radiologists? In 1965, as I said, angioplasty was developed. 1967, the Judkin's technique of coronary angiogram was developed. And before the cardiologists, it was interventional radiologists who used to do coronary angiograms. And Judkin was actually a disciple of Dr. Charles Theodore Daughter. He was a cardiologist, and he took over cardiac interventions, and the cardiology then developed separately. In 1969, the stents that we use now were developed. 1970s, occlusive coils that used for embolization were developed. 1972, selective arterial embolization with GI bleed, which we use very commonly in our hospital and in all hospitals, interventional radiologists. Any patient with GI bleed, if he comes in shock or significant bleeding, our reference directly goes to interventional radiologist. In 1974, selective arterial thrombolysis was developed, now used to treat blood clots, stroke, or DVT. 1980s, biliary stents, 1982 TIPS, 1983 balloon expandable stents in periphery. 1985, self-expand cells are developed. 1990, RFA for liver tumors. And now, according to the present BCLC 2022 guidelines, the latest guidelines, radiofrequency ablation or microablation is now the treatment of choice for lesions less than 2 cm hepatocellular carcinoma in cirrhosis patients and not surgery. In 1991, aortic aneurysm stent grafts were developed. 1994, balloon expandable coronary stents were developed. 1997, intraarterial therapy for tumor killing Virus and gene therapy vectors were developed 1999. Percutaneous delivery of pancreatic islet cells to liver for diabetes were developed 1999. Endovenous therapy for varicose veins were developed. So this chart actually covers only the interventions that were developed in the last millennia. The present millennia, we are not even included. Just going to some few cases very fast. This is a 64-year-old male patient referred to a hospital for DVT management. And when the patient came in shock. So obvious, the first diagnosis we thought was pulmonary embolism, but unfortunately for the patient, it turned out, unfortunately for the patient, it turned out that the patient had a aortic aneurysm, aortoiliac aneurysm. You can see this is a crescent sign of aortic aneurysm. This entire thing is the aorta. This entire thing is aorta, and iliac artery, right common iliac artery actually. And this is a crescent sign that suggests impending rupture. It had already ruptured. This is a hematoma outside the calcium. So it's a ruptured aortic iliac aneurysm. This is a actual coronal picture. This is a aortic aneurysm. This is a right common iliac artery aneurysm. And in such cases, because we had to take care of the aortic aneurysm, we cannot let the embolus, when we mobilize or when we touch the aorta, there's a possibility that the DVT may go and cause pulmonary embolism. So we put an IVC filter here and coil the right common iliac artery. And this is an aortogram. I just go quickly because I've been told that we have 10 minutes time. And this is a stent graft put. This is a stent graft and no filling of the aneurysm. This case was done around 4 years back, and the patient, the reason I include the case was that the patient came for a follow-up 1 week ago, and the patient is absolutely fine. So this is 1 month later, we remove the IVC filter, and this is the left iliac artery aneurysm, we coil that also. And we have a dedicated Lisie aorta team in Lisie hospital. We take care of all the aorta cases, we admit the cases ourselves. It's a teamwork, and there is a thoracic aneurysm we have treated. And now actually, traditionally, aortic stent grafts were done via femoral cut down. Now we have moved past femoral cut down, we have moved to something known as PIVA, that is percutaneous endovascular aneurysm repair, in which hardly 1 centimeter nicks on both groins are put, and the stent grafts are put there, and the access sites are endovascularly put. So what happens is the patient can be mobilized the next day, and in 3 to 4 days, the patient can be discharged. And all the complications of femoral cut down, like lymphocyte or lymphoria, can be avoided. So actually, it's not that we did the first case in the world, no. We are just following what the Western world is following. The Western world is totally following the percutaneous endovascular route. And we are proud to say that we are the only center in Kochi that are doing exclusive percutaneous endovascular aneurysm repair. We have not taken a femoral cut down for the last 1.5 to 2 years. So we have a dedicated venous management team. I'll just show you this. A typical case, how a patient comes with pain, edema, and discoloration of the legs. This is a typical varicose vein patient. These are various stages, CAP classification. I'm not going into the detail. So we do the largest number of varicose vein treatment in Kochi right now. And we do laser mainly because the guidelines, all the guidelines put EDLT as the first line of management. But other lines of management like Vinasil and all the other modalities are also available. And there is something known as secondary varicose veins. Actually, it's very important to distinguish a secondary varicose vein from a primary varicose vein. This is a case, a similar looking ulcer, a long-standing ulcer. This ulcer was there for around 20-30 years. But when you take the history itself, varicose vein patients actually, history is very important. In this patient, there was a history of an accident before around 20-30 years. Sorry. Yeah, 3 years, sorry. 3 years back. Other patient is there. Oh, yeah. 3 years back. And he had prolonged immobilization, and he had swelling in the legs. And there was a documented case of DVT. So this is not a case of varicose vein. This is a case of post-thrombotic syndrome in which the DVT was treated just with anticoagulation. And what happened is, after DVT, the valves get damaged, the veins get stenosed, and the person develops first edema and discoloration, and they can end up in ulcerations that are very difficult to do, very, very difficult to treat. So this is not a varicose vein, this is a post-thrombotic syndrome. The treatment is completely different, even though you will see varicose veins in the skin. And many patients actually come to us with treatment of varicose veins. Actually, treating varicose veins in these patients can make the situation much worse, because varicose veins are now the conduit to carry blood to the heart because the deep veins are occluded. And if you treat those varicose veins, the drainage is gone, edema worsens, ulcer worsens. So proper history taking along with a proper Doppler exam is very important. So in this case, we did not do anything, just gave him a 3-month post-compression stocking and calf physiotherapy, and this is ulcer after 5 months. This is another ulcer, this is 20-year case. Patient had a history of hip displacement with prolonged immobilization. There is no documented history of DVT in this patient. So prior history of prolonged immobilization is very important in these cases. And if there is a such history, you always do a proper Doppler examination, and you definitely look for a case of central vein stenosis. So in this case also we gave post-compression stocking and calf physiotherapy, and the ulcer healed. This is another case, left lower limb, recurrent ulcer for 2 years. And Doppler showed suspicious left common vein stenosis. And this turned out to be a case of May-Thurner syndrome. May-Thurner syndrome is nothing but compression of the left common vein by the right common artery and the vertebra. The common vein gets compressed or sandwiched between the right common artery and the vertebra and gets occluded or stenosed, thus reducing the central venous supply, drainage, and increasing the pressure in the legs. And these cases don't simply resolve, we just treat them varicose veins. We have to go and stent that. And here we have gone and opened up the artery, vein, and this is a stent that has been put in place, and the ulcer healed. So it's very important that all the venous ulcers will look the same. But it's very important to differentiate between a primary varicose ulcer and a secondary varicose ulcer or post-thrombotic syndrome, and only treat according to that. The treatment for a simple varicose vein is EVLT, laser, or varicose vein stripping. That was the old treatment. Or RFA is there, vena sealis, all those treatments are there. But they are not the treatments of secondary varicose veins or the post-thrombotic syndrome. Next, we have a comprehensive diabetic foot management. This is a 90-year-old male with ulcer right foot, patient keeping leg in flex position due to pain. This patient actually, it's a 92-year-old male patient. The patient has such a severe pain that he was not keeping his legs straight for last 1 month. But 1 month back, patient was ambulant. So we know that this is a chronic contracture. This is acute. Due to pain, the patient is keeping the leg in flex position. So in this situation, what we can do is that the Doppler examination showed severe reduction in flow. It was a diabetic ulcer. You can see the ulcer here. And we gave the option, he was a 90-year-old male patient, we gave the option of palliative management, we gave the option of amputation, but the bystanders, they wanted a proper treatment. They were aggressive actually. And we also thought that the patient was ambulant 1 month back, so he deserves a chance. But the challenge in this case was that for doing any procedure, we need the leg to straighten out. So we gave general anesthesia, we gave nerve block, but still the leg didn't straighten out. The patient continued to hold his leg in the flex position. These arteries, very bad arteries, occluded distal SFA. So in this case, we modified the technique. Along with angiogram, we combined ultrasound, and we crossed the lesion, and we did plasty, and this is a final angiogram showing good care. So this is acute limb ischemia. This is a post-COVID phenomena. Actually, the esteemed audience is full of physicians. So you are the people who are at the forefront of COVID management. And you know that COVID, the major complication was post-thrombotic syndromes, the acute thrombotic syndromes, whether acute limb ischemia or DVT or stroke or cardiac issues. All these incidents were highly increased. In the case of acute limb ischemia patient already had gangrenous toes. But the good thing was that the patient had some movement in the proximal interphalangeal joints. So a slight possibility was there that we could save the patient. And in our hospital, we have the motto, save limb, save family. By saving a limb, you just don't save the patient, you save the entire family. A person loses a limb, especially both legs, the entire family's burden, not just financially, but also socially. So we have the angiojet system in our hospital. And actually, Lisie is the only hospital in Kerala that has its own angiojet system. There's an acute mechanical thrombectomy system. That's the latest that is available. And we open up all the arteries, and then we ask the patient by sense to pray that whatever we can do, we have done. And rest, it's not in our hands. And this is how he came back. He lost his toes, but he still could walk with both legs with a shoe. Next, prostate artery embolization is 10 minutes over, sir. If you can, I can just wind up. Can you, sir? Yep. 5 minutes, sure. This is a case of 65-year-old male patient. This is another scenario that the physicians commonly encounter. 65-year-old male patient with post-CB 20 years back. Patient has symptoms of poor urinary stream for last few years with frequent micturition at night. History of hematuria for 1 week on catheterization, IPSS score was 8. This is a very common scenario in elderly people in which patients are not able to pass urine or they have frequent micturition at night. And the traditional or the gold standard even now is transurethral resection of prostate. But many patients are not candidates for that, especially cardiac patients. Other than that, patients who are sexually active, who don't want complications like retrograde ejaculation. So in those patients, we have the additional option of doing a prostate artery embolization. Prostate artery embolization was developed around 15 years back in Portugal by interventional radiologists. And it's a well-established technique, and in international guidelines, it's an accepted technique as an alternative to TRP if the patient is not suitable or if the patient is not willing for surgery. So it's very highly essential that this angiogram for the prostate, we have candid the prostatic artery, and this is the prostatic artery embolization has been done bilaterally. And it's highly advisable that you have a cone beam CT and biplane system, especially a cone beam CT, that you can do a CT scan in the cath lab itself. And 1 week later, the catheter could be removed. In all the patients that we have done till now, the catheters could be removed. It's not necessary that the patient comes to us with catheters, no. If the IPSS score is significant, then the patient warrants treatment, especially, but we never do the treatment without any urology consultation. Our urology consultation is always sought, and it's a combined treatment. It's a combined decision, what is the best procedure for the patient, but the final decision lies with the patient, what he wants to do. So this is the evidence of prostate artery embolization. Yeah, thank you so much.
Thank you, Dr. Lijesh Kumar, for that
Thank
excellent presentation. I now request the second speaker, Dr. Aswin Padmanabhan, for the second talk. We will have the discussions at the end of the talk.
Thank you so much for this opportunity. Actually, it is quite homecoming for me because both my parents have been doctors, and from very small age of mine, I have been regular visitor for IMA conferences. I don't know what I was doing there, but anyways, running around with dad and mom, it's quite a nice thing. One of the best IMA halls in Kerala for sure. It's really nice that I could present a topic here. I'll be just covering around minimally invasive approach to which is a future for neuro interventions. Actually, intervention radiology has exploded in all directions. Whatever subject you take, urology, cardiology, or whatever be the subject, it's exploded in all directions. And each intervention radiologist mostly covers all areas, but takes some niche area as their own interest and then develops that. So I myself have taken neuro intervention as my interest area, and that is what I primarily concentrate on, doing all the rest of the stuff. It's okay, fine. So I'll be concentrating on how neuro interventions have changed over a period of few years. So in the scale of other departments, like anything, surgery, medicine, or whatever, the scales generally 50 years, 100 years, in the sense how when antibiotics were identified or when a particular drug was identified. And the scales are generally like that. But in intervention radiology, the explosion happened quite recently. The scales are quite like months, like 10 months before we did not have a particular catheter, but now we have a particular catheter which can reach a particular place. So that is how fast intervention radiology is growing, and it is difficult for us to even catch up. So we regularly have to attend meetings, and each meeting we go, we find new things happening there. And for us to catch up with that is really a big challenge. So it is difficult for any other department to keep in touch with how much we have grown over the past few years. So I will just show how much neuro interventions has grown over the past few years. Now, any disease per se, people don't want to have open surgery as much as possible. Anybody, you, me, or anybody, people don't want the idea of opening up a person as much as possible. The idea of treating diseases on a day-to-day basis, day cares, OBLs, office-based labs are coming up big time in US. They just want the procedure to be done on a particular day and then go back home. Even the best 5-star facilities or whatever we can provide to them in a hospital setting, they don't want to stay there. Most of them want to just come and do the procedure and go back as early as possible. And so that is why minimally invasive techniques have grown so much. And by nature itself, because we are intervening as less as possible, the complications also are quite less, like wound-related, hospital-acquired infections, even financial benefits per se, because though the procedure might be a little costly, we can send back the whole patient in 1 or 2 days' time, which otherwise would have taken 7 to 8 days. So financially also, many a times it is beneficial. Cosmetic advantage, many patients want cosmetic advantage. As you know, phenol incisions in gynecology, earlier on, easiest for the surgeons to cut vertically, but they had to go to phenol because it is cosmetically beneficial. So even cosmetical advantage is what intervention radiology can provide in many places. Every single pathology, minimally invasive technology is coming up per se. So in neuro interventions, stroke, intracranial aneurysms, dural fistulas, AVMs, and SDH. So these are just few examples which I've just quoted. And one place where we all have to know which is the stroke area. Why? Because even in my, I am assuming if you take an average, I might be falling in the mid category. But even when I was doing my internship in casualty, we did not have such eagerness to go and treat stroke, because in our times, stroke was a diagnosis which did not need triage, because what much can we do? We can give aspirin, clopidogrel, that was the best we could do. So very recently is 1994 is the first time they started giving thrombolysis for stroke. And this is the first publication. Can you imagine the first publication in stroke for thrombolysis was 1995, which is not very long back. In 1995, they did first few number of cases, thrombolysis, within 3 hours time. And imagine within 3 hours time, very few patients came. So those patients showed some sort of benefit, which is around 25 to 30% of the population showed some improvement in the. So that is the first time they realized, okay, if you do certain time-bound interventions in stroke, patients can have benefit. So that is within 3 hours time. So people became little more eager. They started doing in 5 hours, 6 hours intravenous thrombolysis. That is injecting thrombolysis through transvenous route. They started doing in 5 hours, 6 hours. But they then realized that progressively all these studies showed that intravenous thrombolysis was not showing much of improvement. Hardly 10 to 15% of the population was improving. That is because of two reasons. One, when you're injecting IV, the amount of dose that is getting into the clot is very, very less. So, and most clots are generally large vessel occlusions, which cause significant stroke. So these populations were not getting benefited by intravenous routes. So then they obviously started trying intra-arterial route. They had small catheters which could get to the clot and inject thrombolysis directly into the clot. Now that showed some sort of better improvement. And so they conducted one study called the PROACT study, in which one arm was patients who had intra-arterial thrombolysis and the other was IV heparin. And they started and they showed some improvement, but what happened was in halfway of the study, intravenous thrombolysis got accepted. So then the study became unethical, because one arm was getting only IV heparin. So they had IV thrombolysis coming up. So this study had to be stopped in between. But this study did around 45 patients, and for a significant number of them showed improvement. Significant by I mean about 40%. 40% showed improvement in thrombolysis. And then extra arm was added, and the PROACT 2 study came out showing significant benefit for thrombolysis. Even then it was around 35 to 40% of the population. So people tried different things. They just had to get the clot out. They tried ultrasound, they tried all these mechanical things somehow to get the clot out. But one of those particular devices which was shown here, which is called the Mercy device, had one screw-like thing. So this is primarily done for the periphery. Whenever there's something flies off, they put this and they just pull it out. So they tried the same thing for neuro territory, and they found out that there was some improvement in the outcomes. So they started using this for stroke. As you all know, everything, whatever be the drug or whatever it is, has to go through significant studies. But they're very tricky, like all medical companies are. They did something very tricky thing. So if you have to put up a new device in the market to show that it is a new device, they have to do a proper RCT. But in this particular device, what they did was they showed that it is something to do only remove clots, which is already done before. So if you are putting up something new in the market, which is already being done, they don't have to do a study. So they just changed the words in such a way that it can be introduced in market. They actually did about 10,000 cases before the first RCT was done. And I'm talking about 1998, around 2000. They had already done 10,000 cases of stroke, even without the first RCT being published. So Then the government realized that they needed RCT, and then 2013, the first 3 RCTs were came out, and all 3 RCTs showed that intervention is not beneficial. Intervention was not beneficial for stroke. So that was the failure of 2013, and it was a big explosion because that was a time when I just joined radiology. I know these things are happening. So at that point of time, intervention radiology was thought to be a hoax because it was not going any benefit. But then they realized there was some problem in all these studies, that they did not keep a time barrier for it. Most of these studies did not require the patient to be imaged. Any patient who came with stroke went for mechanical thrombectomy. So then they totally changed the criteria. Nowadays, the criteria tend to see patients within 6 hours time. 6 hours is not a criteria anymore now, but generally within 6 hours time, patients have to get a CT scan done, should not have significant infarcts. So these were the criteria which were used in the 5 studies in 2015, and all 5 were showing success. So after 2015, standard of care for stroke, as of today, is mechanical thrombectomy. So any patient who comes within the window period, which is technically 6 hours, but can be extended to 24 hours depending upon person to person, can go for mechanical thrombectomy. I'll just give you a case example of 52-year-old person, right side complete weakness and aphasia, came from a peripheral hospital. She came within 2 hours of time, vitals were stable. NIHS is the score which is used to grade stroke, as you all know. Score of 20 is quite high. She had dense upper limb and lower limb weakness. Immediately as she came, we have a stroke protocol, and the patient went in for CT scan. And this CT scan showed MC. I'm sorry, I'm not able to scroll per se, but it showed an dense MCA occlusion. So here is the angiogram which shows, see there's the opposite side MCA, but this side there is no flow. We can just, within less than about 12 minutes, we can put a stent and just pull it out. This is the clot outside. And this is the patient about 2 to 3 days after the procedure. You can see she's already started to walk and lift her hands and move. So this patient gets discharged about 4th day or 5th day with almost complete power. I'm not saying that all stroke cases are such miracles. There are many cases. What we expect is around 60 to 70% of patients show significant improvement if we choose the patient correctly. So first thing which we need is to have a good stroke protocol. Choose the patients which can do, which can go for stroke mechanical thrombectomy, and then take over the patient, because each procedure comes with significant cost. So we have to choose our patients so that we can benefit them. The success of the procedure are actually not on the table. On the table, it's relatively easier procedure. The success of the procedure is from the periphery to the hospital, and how we choose the patients and how they get onto the table. On table, it's a relatively easier procedure. So that is about stroke. I'll just quickly go in another 5 more minutes about other neuro interventions, how it has exploded. As you all know, clipping was the procedure of choice for most aneurysms. Aneurysm is dilatation of aneurysms. I don't need to tell you, but so when you have an aneurysm, clipping was the procedure of choice some time back. Nowadays, we have something called as coiling, in which we can put a microcatheter right into the artery and then put coil materials inside it, which can occlude the artery. But again, each step we had challenges, because here what you show is a narrow neck aneurysm. By narrow neck, I mean is that when you put coils, it will stay inside. So surgeons had an upper hand when it comes to wide neck aneurysms, where you can't put a coil. But again, within few years, this thing came up that we have a balloon where we can inflate a balloon and put coils inside, where coils will stay. Again, if it's still wider, we can put a stent and then coil. So now the latest studies are that surgery and endovascular coiling is outcome-wise equal. As of today, the study is about 4 years old. Outcomes of endovascular coiling and surgery is equal, and now within last 4 years, many more things have come up, and I am almost sure that endovascular coiling is pretty much more safer than surgery nowadays. So within a span of 25 years, a detachment mechanism like this has come to this size. So that is how fast intervention radiology is growing. This is my personal case where there's an ACOM aneurysm. You can see the aneurysm. The microcatheters are so small that we can reach into the ACOM quite fast. And using a balloon, we can put coils right inside. And this is the post-coiling angiogram, which shows almost complete occlusion of the aneurysm. Similarly, one more aneurysm where posterior communicating artery was arising right from the neck of the aneurysm. Because it was wide, we could not place a balloon, so we placed a stent here, and post stenting we can still see PCOM filling. And these procedures around 2 to 2.5 hours. And post procedure, patient is extubated and perfectly fine to walk. So that is how they don't have any openings, they don't have any critical. Within 2 to 3 days, the patient can be discharged and they can go home if they don't have vasospasm. So a little more complicated case where there's a wide neck aneurysm. You can see that two arteries are arising from the base of the aneurysm. Maybe 4 years back or 5 years back, this was a difficult case to perform, but nowadays we have such supple stents which can be placed onto the both arteries, and coiling can be done. This is called Y stenting, and here you can see the catheters can be taken well into the aneurysm. The catheters are so soft nowadays that you can actually take it well into the aneurysm and start coiling something like this. That's the post-coiling angiogram. Showing good occlusion of the aneurysm. So this is again something which we have superseded surgery in a large way. Now this is another patient who had a different pathology called dural AV fistula. Now here you can see this is a vertebral artery angiogram showing direct communication of artery to the veins of the eye. So right from the base of the skull, veins are getting high flow blood from the artery, and this is a surgical nightmare because you have to open the skull and get to the base of the artery. There will be a lot of vessels there to embolize, to get to the bottom of things will be very difficult on surgery. While endovascularly, we have an option where we can get through the veins from the anterior of the eye like this, very, very small opening, just put a catheter. We can go all the way posteriorly. So here you can see a catheter going right from the orbit all the way posteriorly. I'm sorry, I'm not able to scroll this here. So here you can see the coil coming up. Now this is the orbit. I don't know if you can notice, the coil is going posteriorly. From there, we can go all the way to the base of the skull and coil it. So this patient had, from this condition where it was reflexing into the orbits, from there we have completely occluded this. This patient is symptom free within 2 days of procedure, and for a patient whose surgery could not be done at all. Similarly, like that, AVMs, massive AVMs in the brain which cannot be surgically operated, we have the option of doing onyx embolizations. So on every pathology nowadays, we are having more and more technology coming up, making it easier for endovascular route to target these things in the brain. And I just talked about neuro interventions. There are ever so many options in other parts of the body where interventions coming up, and these things are actually options which we need to give the patients. There is some restriction nowadays because it's one thing is rapidly coming up, second thing people don't know about it, and thirdly there is some issue with how can we whose patient is it my patient, is it your patient, kind of thing. I think we have to offer the best to the patient and let them choose whatever it is. So offer the best to the patient and see, some people would only want surgery and some people would want endovascular option, but for us to know what can be done and what can be offered, these kind of meetings help for such things. Teamwork is definitely the key. Thank you so much for everything.
Thank you, Dr. Aswin, for that excellent talk. You gave us a bird's eye view of the neuroradiological procedures. Please sit down. Now we'll have a few questions. I'll start off with the first one. What is the thing that is limiting the expansion of neuroradiological services? Is it the economic part, the expertise, or the equipment?
So, hello. I think you pointed out the 3 parts, exactly 3 points which is limiting the growth of neurointervention. One is definitely the equipment. Most neurointerventions require the best quality machines to be in place, because each thing is, we are talking about in millimeters. We are not talking about in centimeters. Each coil is around 3 millimeters, 2 millimeters, 1.5 millimeters. So to have a precision of that, we need the best machines in town. And I'll tell you, one of the reasons why I chose Lisie to join was because they invested big in the best machine. I'm not advertising for Lisie. I had options to go to other places as well, but this is the only machine currently in Cochin which has got this good machine for neurointervention, and I'm that way very fortunate to be working in that setup. Secondly, the price. Generally, the procedures are little bit more costlier than surgical options, but Nowadays, because more and more competition is coming up, different companies have started producing the same thing, and that is reducing the price. The coils which were earlier on bought for 1.5 lakhs to 2 lakhs are now being sold for 30,000. The latest one has come for around 21,000. So things are actually cheap because their companies are making money out of it. That is the reason why. But because there is more and more competition coming up, now things have become cheaper. And also expertise. There is definitely lack of expertise because like I told you, this subject is hardly 10 years old. Even during my MBBS, post-MBBS, post-MD times, I did not know what. In my MD days, I have not seen a case of neurointervention, not a single case. So after my MD is when I went to a different center and observed this and found out, oh, this is an awesome place to be, and that is how I chose intervention. So only very less number of radiologists are actually exposed to the idea of intervention, and especially neurointervention. So all these three are limiting factors, and we are trying to bridge all that as early as possible.
Just my take on that. Awareness plays a big role in the sense, in most of the cases of SA, subarachnoid hemorrhage, the patient doesn't have the idea that an interventional radiology or a coiling option is there. Because majority of hospitals, what we can fortunately say is that all the major hospitals of Cochin, except for barring a few hospitals, they have interventional radiology facilities, and endovascular coiling can be done in all these hospitals. So barring those hospitals, even in other districts of Kerala, especially in Thrissur, areas like Thrissur and even Kottayam. Kottayam, it's picking up now. Thrissur, there is a dearth of interventional radiology services there. Neurointerventions are hardly done in Thrissur. So it's a field that requires more and more operators, more and more people have to pass out, they have to take up this thing, they have to get trained neurointerventions. Basically, it's an awareness issue. Cost comes later. But personally, if God forbid, if I have an SAH, I'll definitely prefer coiling than an open surgery, because I can go home after coiling, I can just go home as a normal person in few days. Whereas if you are subject to surgery, I'm not saying anything against surgery, but it's a personal preference. And that's what I've seen in patients also who are given counseling in both. They always prefer the endovascular part. Nobody wants their head to be cut open. And the skull has to, if there's significant bleeding, edema is there, the skull has to be kept in the abdominal wall for few weeks or few months together. So there's a future of interventional radiology, but awareness is definitely lacking.
God forbid Lijesh has it, I'll be the person doing it.
Any more questions?
So no, most patients don't need dual antiplatelets, but only ones, which is about 10% of the population who needs stents. Only 10% needs stents. Those people need to have dual antiplatelets, but 90% of the population we try to avoid, because primarily these patients have people who are come with bleed. So we don't want to give antiplatelets in patients who already have had bleed. Unless we need to stent those patients, which is less than 10% of the population, we try and avoid dual antiplatelets.
No, sir, no, nothing like that. TURP actually is still the gold standard. There is no doubt about that. The advantage of, there are certain advantages of TURP, that TURP gives us immediate relief, and the chance of repeatability of the procedure is less in TURP. You create a pathway. What I always tell the patients is that, just imagine that there is a tunnel that is blocked. In TURP, what we do is, we scrape open the tunnel. So the relief is immediate. It is definitely there. And the chance of repeating the procedure is less. In TURP, what we do is, we shrink the thing that is causing the blockage. So it will take some time. At least 1 week it will take 1 week for the symptoms to reduce. And other issue with prostate artery embolization is that during angiogram, we can embolize the major arteries that are supplying the prostate. There will be very tiny arteries that are there that we are not able to see on angiogram. They may still be there, and that may again supply the prostate, and the prostate can again grow back to size. So the chance of recurrence of symptoms is high with prostate artery embolization. Chance of repeatability, but it can be easily repeated. There is no scar there, nothing is there. The prostate doesn't get bad, there is no complication. We have never seen a complicated prostate artery embolization in our practice till now. And the advantage of prostate artery embolization is that the complication that associated with TURP, that is main, is incontinence. The chance of incontinence is very less in TURP, but the patient who has incontinence has had it. His life is hell. He has to wear an adult diaper for lifelong. He cannot go to social functions. Nothing can be done. There is no treatment for incontinence that comes after TURP, if the patient has that. Second thing is if the patient is sexually active. TURP, almost always you will get retrograde ejaculation. So person who is sexually active, that's a very distressing problem. So the complications that associate TURP can definitely be avoided with prostate artery embolization. So it's always a team effort. It's never a decision that is taken by us alone. Because if you take the NICE guideline, and I consider NICE guidelines to be industry free. It's a UK-based guideline, NHS-based guideline, so industry has no role in that. In NICE guidelines, what they say is, prostate artery embolization, it can be offered as a treatment for BPH, and it has to be performed by a trained endovascular interventional radiologist in consultation with the urologist. That's what we do. All the cases that come for prostate artery embolization in our hospital, we make sure the patient has taken a urology opinion either in our hospital or from an outside hospital and has been offered surgery. For mild symptoms, we never do prostate artery embolization. Which one, sir? Whole lip is other options, sir. Whole lip incontinence is less, definitely it is less. But whole lip also has its share of complications like stricture can be there. And stricture second to whole lip is also, can have severe symptoms, sir. Severe complications. So all procedures, it's not like prostate artery embolization is going to change the future, nothing like that. It's an alternative to patients who want to avoid these complications that are associated with surgical procedures.
I'm sorry, we'll have to wind up because we have overshoot the time allotted to us. Once again, I'd like to thank Dr. Lijesh and Dr. Aswin for their excellent presentation and for giving us an overview of the procedures that are being done there. Thank you.